Okay, very well then. So we go ahead and schedule, and I would like to introduce our next speaker. Now we go back to India. It's Dr. Manali Satiza.
Yes, good evening, everyone. I hope you can hear me.
Yes, we can hear you, we can see you, and we are curious about your presentation slides.
Okay, I'll start sharing my content. Okay, can you see the slides?
Yes, perfect. Thank you.
Okay, this is Dr. Manali from PGI Rohtak, India. I'll be presenting today about immunophenotypic analysis of non-Hodgkin's lymphomas. And this is a flow cytometric analysis at a tertiary healthcare center. Okay, so this is just the background. As we all know, the current WHO classification, it states that all the non-Hodgkin lymphomas, they cannot be classified on the basis of morphology alone and should be supplemented by ancillary studies that can be done by flow cytometry, immunohistochemistry, and molecular studies that includes cytogenetics, NGS, fission, etc. Okay, so to start with, what are non-Hodgkin lymphomas? They are just a heterogeneous group of chronic lymphoproliferative disorders originating in either B cell, T cell, or NK cell lymphocytes characterized by abnormal proliferation of monoclonal lymphocytes in the peripheral blood, bone marrow, lymph node, or any other lymphoid tissue. And as we all know, they represent one of the major health problems and they are of concern. So we need to study them in pretty detail. So these are the most common B cell non-Hodgkin lymphomas that we come across in our region. They are CLL. The CLL is the most common NHL we come across in India, followed by prolymphocytic leukemia, follicular DLBCL, mantle cell lymphoma, hairy cell leukemia, marginal zone lymphomas, and other extranodal lymphomas, followed by other common T cell and NK cell lymphomas. These are T cell prolymphocytic, large granular lymphocytic leukemia, CLPDs of NK cells, and others that you can see in the updated 2016 WHO classification for non-Hodgkin lymphomas. I'll not go in detail about the classification. So how do we proceed to a patient for the NHL? Okay, so in any case of NHL, we start with the clinical examination and lymph node FNAC followed by lymph node biopsy. But there is a requirement for the examination of bone marrow biopsy. Why? Because it's an important part for the staging procedure. If a patient is presenting with the bone marrow involvement, the patient is having stage 4 disease. Okay, so the bone marrow, the alone morphological evaluation for bone marrow to assess the involvement in lymphoid malignancy can be problematic at times, because the morphologic alone cannot subtype all the subtypes of lymphomas. Also, it can be a painful procedure for the patient. A lot of patients here are non-compliant. It's a painful procedure, so they do not provide a consent usually for that. So why do we need, so here comes the role of immunophenotypic studies in the diagnostic pathologies that can be done by flow cytometry, that can be done on peripheral blood or bone marrow aspirate. And the second is IHC, immunohistochemistry, which has allowed a more precise diagnosis and characterization of these disorders. Okay, so what is the role of flow cytometry? It is a diagnostic test that provides a rapid diagnosis and faster results. We usually get results within 4 to 5 hours, and then we can hand over the report to the patient. It analyzes broader array of antigens with a quick multi-parametric analysis of large number of cells. It allows detection of expression of 2 or 3 antigens on the same cell at the same time. Okay, so keeping in view these advantages of flow cytometry, our aim and objectives of the study were to study the IPT profile of non-Hodgkin lymphomas by flow cytometry in peripheral blood and bone marrow. And form a minimum primary cost-effective panel for diagnosing NHL. Because in India, as we all know, everybody is not enough financially stable to provide to perform a highly very costly test like ancillary studies, including molecular study. Every patient cannot afford it, so we need to form a primary panel. As flow cytometry, it's also a little expensive test, so we need to form a minimum primary cost-effective panel that can be used for diagnosing NHL, followed by further subtyping of the cases based on IPT profile that is used in WHO classification. Okay, so this was a prospective observational study conducted on 30 cases of NHL in Pandit Bhagwat Dayal Institute, uh, okay, of Health Sciences, Rohtak, Haryana. The inclusion criteria, it were all the clinically suspected cases of NHL, either diagnosed by bone marrow aspirate, biopsy, or lymph node FNAC were used in the study. The exclusion criteria for the study was all the previously treated cases were excluded from the studies, and the precursor lymphoblastic lymphoma or leukemias, along with the bone marrow biopsy length with less than 1.5 centimeter. Okay, so peripheral blood and bone marrow aspirate was processed on flow cytometry. It was performed on an 8-color flow cytometer BD-FSCS Canto 2, and the list mode data was acquired and analyzed by FSCS Diva software. The expression of all the gated events were plotted on the site scatter, SSC CD19 for B cells and SSC CD3 for T cells. Okay, this was the diagnostic panel of monoclonal antibodies that was used on flow cytometry. The primary panel comprised of CD3, 5, 7, 4, 8 for T cells, 19, 20, 23, 79, T, 200 for B cells, CD45 as common leukocyte antigen, CD56 for NK cell, and the secondary panel for further subtyping of the cases that included FMC7, CD25, CD123, CD103, and CD38, that was a marker that was used as a prognostic marker, basically in the cases of CLL. Okay, so this was the immunophenotypic diagnostic criteria that we used as a reference table for classification of the cases in our study. So all the cases, all the B cell lymphomas. So I would like to mention all the cases in our study comprised of B cells, B cell non-Hodgkin lymphomas only, because it was a limited period study that was around 1.5 year or 2 years, and included only 30 patients. So all the 30 patients were of B cell lymphomas. So we will discuss about only B cell lymphomas here. All the B cell lymphomas, they are positive for 1920. And to start with CLL, it is basically CD5 positive, 23 positive, 200 positive. That is a classical marker for CLL these days, followed by dim positivity for CD59 and FMC7. Atypical CLL, all the same findings as above, except for the part it is negative for CD5. Okay, so third, mantle cell lymphoma, it has a classical expression of CD5 positivity and negative for CD23, and it is also negative for CD200. There are recent studies that says that CD200 can be used as a marker to differentiate between the cases of CLL and mantle cell lymphoma. The others were marginal zone lymphoma, hairy cell leukemia, follicular lymphoma, DLBCL, and few of the cases of non-Hodgkin lymphomas, they remain unclassified because they do not fit into any of these IPT criterias. You can refer this table for the classification of the cases. I'll not explain every single subtype here. Okay, to move on to our results. there was a distribution of the cases according to the age. The majority of the cases in our study were in the range of the age of 41 to 60 years of age. That is a very common age for non-Hodgkin lymphomas usually that we see. And the cases according to the gender, majority of the cases were males. Distribution of the cases according to the lymphocyte count. In the majority of the cases, the lymphocyte count was more than 5,000, the absolute lymphocyte count. I'm sorry, there is something with my presentation over here. That's some error. It's not able to, it's not clear over here. I'll share it with you later on. The clinical presentation of the cases, I'll tell you, the most of the patients presented with the presentation of fever, weakness, and lymphadenopathy. And the distribution of the cases, all the cases presenting clinically with NHL symptoms and any finding on FNAC or lymph node biopsy were further proceeded for bone marrow aspiration examination, and all the bone marrow aspirates and peripheral blood of those patients were subjected on flow cytometry. So after the flow cytometric examination, all the cases were divided into a broader subgroup, including CLL and non-CLL group. So why CLL and non-CLL group? First of all, it's very important to differentiate CLL and non-CLL group, because all the patients of CLL, they do not require treatment usually. Here, the patients of CLL, until and unless presenting with symptoms, they are kept on follow-up for very long periods. Okay, so this is very important to differentiate between both of them. And the other part, to differentiate between CLL and non-CLL group, we just required a minimum basic primary panel that can be very cost effective at our and money saving for the patient as well. Because for the classification of differentiating between CLL and non-CLL, will require just a B cell marker, CD5, 23, and CD200. Okay, that's it. So the CLL group in our study comprised of CLL along with a single case of atypical CLL, and the remaining non-CLL cases were further subclassified in using an extended panel into mantle cell lymphoma, marginal zone, and hairy cell leukemia. Okay, distribution of the cases on the flow cytometry. This was the distribution. CLL, majority of the cases on flow cytometry comprised of CLL, and this was the immunophenotypic expression of the CLL cases in our study. Positive for 1920, characteristic presentation, classical, CD23, 5 positive, 200 positive. And all the cases in our study were positive for CD38, negative for FMC7, CD10. They were either kappa positive or either lambda positive. Atypical CLL, as I already discussed earlier, it was positive for all CLL markers except the part for CD5 and CD10, which was negative. Moving on to mantle cell lymphoma, that was the second most common finding after CLL that we observed in our study. It was a classical present immunophenotypic expression, CD5 positive, 23 negative, and 200 negative. Okay, hairy cell leukemia. Hairy cell leukemia, it was positive for the B cell marker 1920, 79. It was also positive for CD200, while the other hairy cell leukemia markers like CD25, CD103, and CD123 were strongly positive, and all these three hairy cell leukemia markers were negative in all the other cases. Marginal zone lymphoma, it was considered as a diagnosis of exclusion because it was just CD23 positive, 79 positive, while negative for 5, 10, and 200. And the few of the cases tend to 12 cases in our study remained unclassified, that we were not able to fit into any of the above subtype. And the expression was they were positive for 19, 20, 23, 5, FMC7, every single marker, but they were negative for hereditary leukemia markers, as well as they were negative for CD200. So the unclassified cases in our study, these unclassified cases were further subjected for bone marrow biopsy examination, followed by immunohistochemical analysis for further confirmation, just to cross-check what was the drawback that the flow cytometry could not evaluate these cases. So we were able to find that due to the lack of morphological assessment, because to look for a few cases like diffuse large B-cell lymphomas, you need a morphological assessment always. Okay, so due to lack of morphological assessment and non-availability of few confirmatory markers, I'll tell you later on, few of the cases remain undiagnosed on flow cytometry. So immunohistochemical analysis on all those cases, we were further able to classify 5 of those cases into 3 into follicular lymphoma and 2 into diffuse large B-cell lymphoma. So it was seen that the morphology plays an important part too in the classification of lymphomas. And as well as 2 of the markers like BCL2 and BCL6 that were required. BCL2 positivity was seen in all 3 cases of follicular lymphoma, and BCL6 in DLBCL. So they were not available on flow cytometry. Hence, the IHC was required. Okay, after using IHC after flow cytometry, agreement between the diagnosis was seen between both the studies to see the accuracy of immunophenotypic findings. So it was seen the percentage agreement between flow cytometry and IHC was highest among the cases of CLL. It was 83.3%, followed by mantle cell lymphomas and unclassified cases. There was no agreement seen for atypical CLL, marginal zone, hairy cell leukemia, follicular lymphoma, and DLBCL, since these cases were exclusively either diagnosed on flow cytometry or on IHC. As I already told you, the follicular lymphoma and DLBCL, both of these lymphomas were not diagnosed on flow cytometry. So there was no percentage agreement counted between these two. Okay. So next, all the markers that we used in flow cytometry and IHC, there was percentage of agreement seen and kappa statistics were applied. Okay, so there was absolute agreement between flow and IHC for all these markers 19, 20, 30, 3, 7, 4, 8, 56, and 45. Why? Because all these markers were either positive or negative, both on flow cytometry and IHC. So we could not apply kappa statistics over here, and the no p-value was calculated for these. But there were few markers that showed discrepancy on flow and IHC. So agreement of the markers for these kappa statistics were applied for these markers: CD23, CD79, CD5, and CD10. And it was seen that the concordance rate between flow and IHC was highest 100% for CD10, and followed by CD23 and CD79 and 5, with all of them showing p-value less than 0.05. So taking IHC as the gold standard test, kappa statistics were applied and concordance rate for every marker was calculated between flow cytometry and IHC. And the concordant markers, as I already told you, were CD23, 79, 5, and 10, with the statistically significant results for 5, 23, and 10 with a p-value of less than 0.05. Okay, so but after these broader analysis, there were few limitations in our study. The sample size was very limited, as only 30 cases of NHL were included in our study. Because our study included only stage 4 NHL cases, and usually the patients with NHL having stage 4 disease, they usually do not survive to a very later stages. And second drawback was lack of morphological assessment. Few of the NHS required morphological assessment in very detail, like follicular lymphomas and diffuse large B cell lymphomas, also hairy cell leukemia cases. There was no availability of BCL2, BCL6 on flow cytometry, and therefore no case of follicular lymphoma or DLBCL was diagnosed on flow cytometry. So why did we perform this study? Because lymphoma, it is one of the major health concern all over the world, and it is increasing day by day. It is a common malignancy affecting both children and adults and increasing rapidly. And our modern pathology, it relies on immunophenotyping for accurate classification of lymphomas. And as we already said, the WHO also suggests that the classification of lymphomas should not be done entirely on IPT or entirely on morphology. It should be a combined approach. It should be on the basis of morphology along with supplementation with IPT. So here in study, we evaluated the immunophenotyping of various B-cell lymphomas by flow cytometry, and those findings were further confirmed by immunohistochemical analysis. And using IHC as the gold standard test, appropriate stats and kappa statistics were applied. Okay, as already discussed, there was no statistics applied on the markers 19, 20, 3, 7, 4, 8. And correlation was found for the comparable markers like 5, 23, 79, CD10, kappa, and lambda. And the agreement between various comparable markers ranged between 76 to 100%, similar to studies done by Dewan K et al. And Bismier KW et al., who also observed a concordance rate between flow cytometry and IHC for the further above comparable markers, and the rates were 80 to 100% and 76 to 100% respectively. Okay, after the individual the CD markers, there was a few a little bit discrepancy about the monoclonality assessment, like kappa and lambda assessment. Because immunohistochemistry, all the cases were further subjected for kappa and lambda staining on IHC, and it was found that IHC was a very non-specific way to assess the clonality of the cases, because it shows a lot of background staining. In 30 cases, 15 of the cases showed lots of background staining. So we were not able to classify them as kappa positive or either lambda positive. While on the other side, flow cytometry was a better method for the assessment of clonality, because all the 30 cases, they were either kappa positive or lambda positive. So monoclonality assessment was very easy on flow cytometry, while it was not on IHC. So can we conclude that, here's the conclusion, can we say it, that IHC is a better tool for subtyping of NHL cases, while flow cytometry was found more sensitive in assessment of monoclonality? We can say this or not, even I don't know, because in our study, the sample size was very limited. So we need further studies to pass a statement for this. But here we can approach a two-tier approach for immunophenotypic analysis of in all the newly diagnosed cases, using a minimum primary panel that can be cost effective, including the markers as 19, 25, 23, 79, 10, 45, kappa, and lambda. Because using just these markers, we can separate CLL cases from non-CLL cases. So at least we can say that the patient with CLL, because it's very important to differentiate between both of them, because the patients with CLL, they usually do not require treatment and can be kept on follow-up. And the remaining non-CLL cases, they can be further subjected to an extended panel. It can be applied for further subtyping of the cases. So these are the references I used for in our study. You can see them later on. So this was my presentation. Thank you so much for listening and paying your attention. Any doubts or queries?